Okay, yeah, very good hint. So it's like, yeah, it's, yeah, correct, correct. So it's like basically you see a orange peel texture, okay, like, or to be more specific, it is microscopic elevation and depression of your connective tissue. Okay, so usually this is a sign of, they say that stippling is a sign of healthy gingiva, sign of keratinization. So what we want to achieve is more of keratinized tissue. Okay, but as you go down beyond the mucogingival junction and all, in the alveolar mucosa and all, it becomes less keratinized. So keratinization is what we try to achieve. Keratinization is basically your thickening of your, you can say it's like thickened appearance of your skin, you can say. So it what keratinization does is, whenever there is, it will resist the trauma or forces more efficiently compared to a non-keratinized tissue. So with regard to gingiva or gums also, we are trying to achieve keratinization more. So, but you see more of stippling, or more stippling means more orange peel texture or more sign of keratinization in adult gingiva compared to that of children's gingiva. Okay, so having said that, I would like to say that you will not see stippling in a very small child. Okay, say for example, if the child is less than 3 years of age, okay, it is normal for the child to not having stippling. Okay, that is a normal phenomenon. You cannot associate that with what, a gingival disease. That's what you have to keep in mind. Okay, so stippling or loss of stippling in children, or less stippling, doesn't mean that the child has, what do you say, a periodontal or a gingival inflammation. It is a normal phenomenon in children. Okay, whereas, and usually we why we say it, because stippling is associated with keratinization, which is a sign of healthy gingiva. Now studies have shown that previously, if an individual who is having a healthy gingiva doesn't have stippling, so he doesn't, if there is an absence of stippling in such individual, it cannot be associated with disease. Okay, so you can, or never, now the concept is, you can never tell that if there is a loss of stippling, there is like what is a periodontal disease. Okay, hope you understood. So basically, in the attached gingiva, you will see less stippling. Attached gingiva is more wider in children compared to that of adult. Okay, and in adult you will see coral pink color, whereas here you will see less dense and more reddish in color because of high vascularity. Okay, and coming to two unique features which you see in the attached gingiva are interdental cleft and retrocuspid papilla. Very important aspect. Okay, because one second, let me see whether I have a picture of it, then you will understand what. Okay, one second. um, oh, there was, okay. Yeah, one second. Okay. Yeah. This can you see this picture in which the coal is mentioned? Coal is a different phenomenon. I'll tell you what coal is. So basically, in you will find this this coal picture, no, like that. You will find that shape. There is a ridge and a depression. This kind of thing. You can see a knife edge here. This knife edge, that is the ridge which you are seeing, is called the knife edge appearance. This usually you will see in what do you say, in adult gingiva. Okay, more of a knife edge margin. That's why I told you, you have to focus on this marginal gingiva knife edge thing. Okay, so basically you will see a knife edged margin with respect to what, like attached gingiva. The margins are having a sharp knife edge, and this area, no, it is said to have more of, what do you say, periodontal issues, because it is less keratinized. Whereas in your attached gingiva, you will find interdental cleft, simply because there is a cleft formation in between two teeth, or due to interdental spacing, which you normally see in children. Okay, so because of this, saddle areas are formed. Okay, I'll just type this because it is not there in the PPT. I think it is there in your PDF. So you will find more of saddle area. Saddle area is something like, if you you know that seat in the horse, horse, when you go for horse riding and all, you have a what do you say, a saddle kind of appearance which you see. Okay, basically, so that kind of saddle areas are seen in the interdental areas, and this is more of having more of keratinization. So you will see less, what do you say, periodontal issues and dental gingival issues in children. Okay, then you have something called as retrocuspid papilla. Basically, this is a retrocuspid projection which is seen with regard to mandibular canines, okay, especially in the lingual aspect of the mandibular canines, you see primary mandibular canines, you'll see this feature. This is not seen very commonly in adults. Okay, if you look at the second picture in this slide, you can see a bulge with regard to the mandibular primary canine. Okay, so this is called as retrocuspid papilla. This is also a unique feature of what children's gingiva. Okay, now coming to papillary gingiva or interdentral gingiva, no interdentral caul formation is seen. Okay, so it is also known as interdentral saddle. I already told you what a saddle is, and as a result, it is less susceptible to infection. Whereas in your adult, you will have a pyramidal or caul shape, more susceptible to infection. So I'll again go to the next slide. Here you can see. So this the third picture here. No, you can see the tooth and the caul is mentioned. So this elevation and depression, the depression, the area which is circled is non-keratinized. So as I told you, we actually strive for keratinization. So because there is a non-keratinized tissue here, this area is prone for infection. So you will see intestinal caul formation in permanent. Sorry. Yeah. Yeah. Can you hear me, guys? Hello. Yeah. Okay. Yeah. Sorry, I got called. Yeah. Yeah. Okay. Yeah. So this intestinal cold, no, is actually seen in permanent gingiva. Okay, or sorry, gingiva of adult. You can see. So this cold area is non-keratinized. Because it is non-keratinized, it is more prone for infection. Whereas you will find saddle keratinized area in case of a gingiva of a child, and it is keratinized, and there is less chance of infection. Okay, very important aspect, intestinal cold. Okay, you should be knowing it for clinical relevance also. Okay, and now coming to gingival sulcus, it is having a more of a gingival sulcus in children. Almost 1.4 to 2.1 is seen, and as I told you, the gingival sulcus area is easily retractable in children. That's why there is more depth, whereas it is more of a tight contact in case of a adult gingiva, and the gingival sulcus is less. Okay, so hope you guys understood the difference in this. Any point you want me to repeat in this, or everything is fine? Okay. Now coming to the difference between periodontal ligament. Okay, so in case of children, the periodontal ligament space is wider and has fewer fibers compared to that of adult. Okay, and it is more fibrous and more vascular in children compared to that of adult. Here the cementum is thinner compared to that of the permanent teeth. So these are the differences you have to keep in mind with regard to your adult periodontal ligament. Okay. Now coming to alveolar mucosa and alveolar bone, again alveolar mucosa, as I told you, the gingiva itself is more reddish in color because it is more vascularized and it has less keratin. Okay, usually less stippling is also seen, which is again a normal feature. Coming to alveolar bone, it is less calcified, again more vascular. It has few and thick trabecular bone. Trabecular bone is basically porous bone, whereas in your adult you will have more compact and dense bone. Okay, and as a result, it is more porous. It will have larger marrow spaces. Lamina dura again will be thin, and flat interdentral crest between the primary tooth is seen when you compare with that of adult, or sorry, with that of permanent tooth. Okay, and this picture clearly a beautiful picture which actually tells you how a healthy gingiva looks, how a inflamed gingiva or just gingivitis, and when it is related to periodontitis, what all you will see. So basically, in your healthy gingiva, it completely fills the space between the teeth, and it does not bleed when being touched or on BOP, they say, right? You see BOP or bleeding on probing in your perio, so that is not seen. And the color of the gum is pale pink. Okay, when you come to inflammation or gingivitis, you see inflamed gums are red and slightly swollen, and they bleed easily on bleeding on probing. Okay, when touched. And when you come to periodontitis, you will find other features like there is recession is seen. You can see loss of attachment, periodontal pockets, etc. Okay, so all these things you already know, but it's the same thing in adults also. Now classification of gingival diseases. Now there is a new classification, I think. Okay, so just for just use broad classification, at least for Pedo's sake. Okay, but don't follow this as a universal this thing, because they have a new classification for periodontal and gingival diseases. Now I think in 2017 the perio people, they have released a new classification to the American Association of Periodontics in 2017 has come up with a new classification. Okay, so this is in general which you should be knowing. Okay, so we classify in broad terms, we classify it as simple gingivitis, acute gingival conditions, chronic non-specific gingivitis, conditioned gingival enlargement, and scorbutic gingivitis. I'm not telling each subheading because we'll be discussing this in the due course. Okay, and again in 1999 classification for International Workshop of Classification of Periodontal Diseases and Conditions, again has classified it into puberty gingivitis, gingival overgrowth due to drugs. Okay, and necrotizing ulcerative gingivitis due to various factors like stress, smoking, and other factors, etc. And again, APD has given a classification based on simple gingivitis, chronic inflammatory gingival enlargement, gingival abscess, pericoronitis, again very commonly seen condition in children. I'll tell you what it is, and acute necrotizing ulcerative gingivitis. So this is the classification. Just know it. At least one simple classification, if you know, that is good enough. Now coming to the etiology, we have local factors like calculus. All of you know about this development and defect of the attached gingiva. Again, that is another issue which actually leads to gingivitis. If there is any defect in the attached gingiva, it can lead to what? More gingival recession and gingival problems, food infections, etc. It will lead to infections and other stuffs, etc. Okay. Then faulty and irritating restorations. If there is a overhanging restoration, it can lead to, or if there is an underfilled restoration, all these things can lead to what? Gingivitis. Okay, so that's why you say after your restoration you have to check the margins. Very important. Okay. Then again, a faulty design of your removable partial denture, if especially if there is a clasp which is very sharp, okay, or not properly attached to the tooth surface, this can again lead to what? Trauma to the tissues as well as lead to gingival issues. Okay, orthodontic therapy again. Again, the what do you say? Personal oral hygiene is compromised when you actually do a fixed orthodontic treatment. Again, a no-brainer. It can lead to what? Gingival conditions. Mouth breathing, especially in patients. I think I already took a lecture on oral habits in which we were discussing about mouth breathing habit. Basically, the child has a tendency to breathe through the mouth, and classical sign which is the adenoid faces, and where you will find the gingival inflammation. Can anybody tell me in mouth breathers? You will find it in one area. Can you tell me which area you will see the gingivitis in mouth breathers? Anybody? Yeah, very good. Okay, upper anterior. In the upper anterior marginal gingivitis, you'll find a classic inflammation. Okay, that is the classic feature of what mouth breathing patients having gingivitis. Okay, again, tooth malposition, crowding, and all those things will lead to gingivitis. Then self mutilation, like debilitating diseases like acute necrotizing ulcerative gingivitis, which we'll be discussing in this lecture. Okay, so these are the local factors. Again, coming to systemic issues, any kind of nutritional disturbances. If you are having what do you say, nutritional disorders, or what do you say, maldeficiency, like improper intake of nutrients, all these things can lead to what? Systemic issues. Drug induced, very important. Not only phenytoin and sodium, there are other drugs like what you say, phenobarbital, nifedipine, etc., calcium channel blockers. All these things will actually cause gingival hyperplasia. Again, we'll be discussing regarding this. So that is another systemic factor which will cause gingivitis. Down syndromic patients, again a genetic disease most commonly seen. There are three types of Down syndrome. I think there is a lecture coming up on clinical genetic conditions in which we'll be discussing about Down syndromic features. A classic feature of Down syndromic patient is that you will, and I think there was a question in midterm, right, regarding this thing. You will not find dental caries. There was a question in level 9 midterm exam in which we asked what you don't commonly see in Down syndromic patient. You don't commonly see dental caries in Down syndromic patient, but they are highly predisposed to periodontal destruction. Okay, periodontal diseases are most commonly seen in Down syndromic patient, whereas you don't see much of dental caries. Okay, again, please make a note of that point. The next one is lesion of genetic origin. Again, genetics plays a role in whether an individual will be having gingivitis and periodontal disease. And again, debilitating conditions like or immuno Yeah, very good hint. Yeah, there can be a delayed eruption of tooth. Okay, and because there is no tooth at all, and there can be internal spacing. Okay, and big mouth can be seen. All those things. You will never have a chance of getting what dental caries. Okay, because the tooth itself is not there. But whereas your periodontal destruction is very prominent. Okay, gingival lesion of genetic origin, and then you have conditions like diabetes mellitus and hyperglycemia, where you will find your periodontal disease as a very common feature. In fact, apart from your diabetic neuropathy, nephropathy, okay, retinopathy, and all these things, your eyes, your kidneys are affected, your neural system is affected in case of diabetes mellitus. Now they say that even periodontal issues are one of the classic signs of diabetes mellitus. Okay, so very commonly seen. Now coming to the first condition which we'll be discussing, that is eruption gingivitis. Again, it is a temporary type or a self-correcting anomaly, often associated with difficult eruption which subsides as soon as the tooth erupts into the oral cavity. Okay, I think even in our pediatric oral pathology we discussed about eruption gingivitis. The greatest incidence is seen in 6 to 7 years when the permanent tooth begin to erupt, as you all know. The increase in gingivitis apparently because the gingival margins receive no protection from the coronal contours of the tooth. Basically, your sharp incisal edges, no, when it is erupting, there is no protection for the gingival margins, and as a result of this, it is said that there may be a gingival issue. Okay. So treatment, usually you don't require any treatment at all. From my personal experience itself, you have to just reassure the parent. Okay, so mild form requires no treatment except plaque control, okay, oral prophylaxis, etc. But sometimes if it is at all, if at all it is becoming very severe, okay, there can be swelling and lymph node enlargement. Then pericornitis, and pericornitis basically your inflammation which is associated with this thing. Okay, it should be treated with antibiotic therapy and professional assistance. So what why there can be swelling and lymph node enlargement? Usually what happens, no, when there's a lot of irritation, very young children, no, when there is irritation to the gums, no, they tend to put something in their mouth. Okay, and whatever they are, there can be some kind of toy or any kind of hard objects. Okay, something which is very fibrous and all, and if that particular thing which they are putting in the mouth is not clean, no, the chance of infection, okay, it can be due to secondary. Studies have shown that basically it is not due to this thing, they are getting fever and malaise. It can be due to the habit which they imply on when they are having this irritation. Okay, so and again, in your chair side, you can treat this lesion with normal saline and hydrogen peroxide irrigation. And again, if nothing subsides this condition, they have to do a surgical excision of the pericoronal flap. Now, coming to primary herpetic gingival stomatitis, again, very important, very important. Okay, again, please highlight this thing with red mark. Okay, this slide. It is caused by herpes simplex virus 1 in children less than 6 years of age. Okay, but what is the biggest problem is very most commonly seen in children. But what this virus does is, no, it will be retained in your body after the primary infection virus gets into your body. No, it ascends through the sensory and autonomic nerves, and it will persist in your neural ganglion. Okay, it will not go away from your body. So, and it will wait for an opportunity. Okay, when is said to be an opportunity, it can be a result of various stimuli which will trigger this again. Okay, it will trigger the neural ganglia, and the second time it will come as a secondary infection or secondary manifestation of this primary herpetic gingival stomatitis seen. So what are the various stimuli? Trauma is one. Fever, okay, when you are stressed out, when you are fever, okay, when you are fatigued out. Upper respiratory tract infections, certain kind of allergic and gastrointestinal disturbances can trigger this again. Okay, and secondary manifestation is usually seen as a condition called as recurrent herpes labialis. Again, underline this, very important. It is included of cold sore, fever, blister outside the lip. Okay, usually you see in the lip area, and it is called as recurrent herpes labialis. Why recurrent? Because usually it is the secondary manifestation. Primary manifestation has already occurred when the child is less than 6 years of age. Okay. Extraoral symptoms you will see: cervical lymphadenopathy, high fever, 101 to 105 degrees Celsius. It's actually, I think it's degree Fahrenheit, okay, not Celsius. Then there is generalized malaise, irritability, and headache is seen. And usually you will find dysphagia or pain associated with intake of food and liquid. Okay, these are the extraoral symptoms other than the intraoral symptoms. Now coming to intraoral symptoms, you will find diffuse or widespread erythematous. Erythematous means reddish, shiny involvement of the gingiva. You will see presence of discrete gray yellowish fluid vesicles. Discrete means distinct and separate. Okay, so you will find distinct, separate gray yellowish fluid filled vesicle is seen. Erythematous shiny gingiva is seen. After 24 hours, what happens to this vesicle? It will start to rupture, and once it is rupturing, it will form what? It will form painful ulcers. Okay. Again, the site of the infection is seen and buccal mucosa, tongue, lips, in your tonsil areas, hard and soft palate. And usually the disease is limited to 7 to 10 days. So basically, you'll be doing like a symptomatic treatment for like any viral infection it comes. No, even if you take medicine or you don't take medicine, it will stay its due course and it will get what subsided after that due course. So this condition will stay for 7 to 10 days, and during this course of treatment you can do only symptomatic treatment. If there is a fever, you will give what an antipyretic. If there is pain, you will give analgesic, etc. So you basically treat the symptom. Okay. Gingival erythema or reddishness is seen, and edema is also seen, and it persists for several days. So they see all you can see reddish gingiva, ulceration formation. Okay, around the lips. Okay, labialis. You can see what these are the features you are seeing. Okay, again you can see lesion in the tongue. So these are the various side this herpetic gingivitis affects. Okay. Treatment, as I told you, symptomatic and supportive treatment only. Okay, basically you have to do symptomatic treatment. Ask the mother to give the child, keep them high, like because there's a high chance of dehydration with like any viral disease. You have to keep them hydrated, all those things. Apart from that, you apply what? For pain, you apply mild anesthetics such as diclonium hydrochloride 0.5 percentage. You can give antiviral drugs like acyclovir, famciclovir, etc. But even though if you give also, it will stay for its due course. Okay. Antibiotic therapy, usually with any viral infection, you will find secondary bacterial infection, so you can give them antibiotics as well. Okay. Now coming to the next important conditions. Any doubts in this thing, guys? I am going a little bit fast because there is one more lecture. I know. Sorry, but is there any doubts? Anything? Okay.
Clear,
Now coming
doctor.
to, yeah. Okay. Okay. Coming to acute necrotizing ulcerative gingivitis, ANUC. Okay, it's an inflammatory destructive disease. It's also known as the other name of ANUC. Please note down. Okay, it's also known as Vincent's infection or trench mouth. Often occurs as acute disease in about 2.5% of adolescent. Okay, not very small children. You will very rare to see ANUC, but in slightly older children you will find ANUC. Okay, when bone loss occurs, this condition is called as NUP. ANUC means it is involving gingiva, whereas when bone loss occurs, it is called as NUP, necrotizing ulcerative periodontitis. Okay, and now it is not known as ANUC. Okay, now it is just known as necrotizing ulcerative gingivitis. Okay, acute is not, the term is not used anymore. It is necrotizing ulcerative gingivitis, NUG, and if bone loss is there, it is called as NUP, necrotizing ulcerative periodontitis. Etiology, usually it is said to be caused by spirochetes or fusiform bacilli, Borrelia vincenti. These are the organisms which cause what? Acute necrotizing ulcerative gingivitis. Predisposing factors, again, when there is a vitamin C or vitamin B12 deficiency, it can be seen along with debilitating disease like diabetes mellitus or an immunocompromised condition. A classic immunocompromised state where ANUG is usually seen is HIV patients. Okay, it can come as an MCQ even for your Saudi Commission licensing examiner. Very commonly asked question. Okay, so ANUG is usually associated with debilitating diseases like when debilitating disease. A classic example is diabetes mellitus or an immunocompromised state, most commonly associated with HIV patients. Okay. It is not there in the PPT. That's why I told you. Oral symptoms. You can see punched out craters on the papillary gingiva. Punched out lesions, again, an important aspect with respect to ANUC. Okay. And you can see pseudomembranous slough. Okay. So punched out craters on the papillary gingiva. There is spontaneous bleeding, and craters are covered by pseudomembranous slough. So this punched out craters and pseudomembranous slough, if it is coming in the question, pick ANUC. Okay. Very important clinical feature with regard to ANUC. Okay. It is extremely sensitive or painful to touch. There is constant radiating pain, and if you take spicy food, it is like adding what oil on fire. Okay, it will actually exacerbate the pain. There is metallic, foul taste or fetid odor or bad breath is usually seen. The saliva is pasty saliva, not watery. So it's again a bad thing. There is high chance of, it can lead to high chance of, what do you say, dental caries as well. External symptoms, you will find localized lymphadenopathy or lymph node enlargement is seen. Again, increased temperature, just like any viral infection, herpetic gingival stomatitis. Again, here also you can see increased temperature. You don't, the patient will not feel eating, okay, because of loss of appetite, basically because of difficulty in swallowing the food, as well as there is because of this constant radiating pain, the patient will not take any food, and there is loss of appetite. Insomnia, the patient cannot sleep. Again, gastrointestinal disturbances, I can be either diet can be seen, or it can be constipation can be seen with regard to this patient. Okay, so that is with regard to the external symptoms. Pseudomembranous slough and punched out lesions, very important aspect with regard to Anuk. Okay, these two aspects just keep in mind: pseudomembranous slough and punched out lesions. Okay, so what you will do as a dentist? First visit, you only actively clean the involved area. Okay, you will not do a generalized treatment. Only where it is very severe, you try to actively clean that area. Areas to be swabbed with cotton, because keeping in mind that the patient can have severe pain, you just take a cotton and try to clean the area. Supragingival calculus has to be removed. Rinse the mouth with warm water and 3% hydrogen peroxide and 0.12 percentage chloroxidine. All these things have what antiseptic properties. Again, you have to give the patient antibiotics to calm down what the inflammation. Okay, so penicillin or erythromycin or metronidazole for 7 days. These are the most commonly prescribed drugs. Okay, the combination of penicillin and metronidazole is said to be very effective. Okay, so you can actually do that regimen for 7 days, and you recall after every 2 days. Okay, in the second visit, you will find that after this initial visit, now if it is done properly, then there will be shrinkage of gingiva exposing calculus. Okay, and that time what you will see, when there is shrinkage of gingiva exposing calculus, you will generally remove the calculus that time. Don't apply too much pressure also. Even in that visit, patient is asked to continue the good work which he has done, continue rinsing and maintain the oral hygiene. In the third visit, again after 2 days, you will do further root planing and scaling. Okay, and continue the oral rinse with chloroxidine only. So you will ask the patient to stop what hydrogen peroxide, you will ask to stop, and you will tell the patient to continue with what only chloroxidine. So that was with regard to okay. Now coming to the excuse me. Now coming to the next condition, which is acute candidiasis. Okay, so it's also known as moniliasis. Okay, this is the old name, and because it was said to be caused by Monilia albicans, but now it is known as candidiasis. Okay, so it is now it is believed that it is caused by opportunistic fungi called as Candida albicans, and there are four clinical types. Pseudomembranous candidiasis in neonates, which we are most interested in, and you will definitely come across at least some patient in your lifetime in which the mother will bring a neonate or a newborn child with this condition, pseudomembranous candidiasis. Then erythematous candidiasis, hyperplastic candidiasis. Very rarely do we see in what do you say, in our pedo clinic, because it is mostly seen in our adults. And the last one, which is angular cheilitis. So what is acute candidiasis? Or under acute candidiasis, we have pseudomembranous thrush or oral thrush. Okay, so you will find it in neonates or newborns. It starts between 6 to 10 days. Cause is directly from the mother itself. Okay, so there is a direct link from the mother to the child. Infection is usually from the mother or the caretaker, whoever is taking care of the child. Appearance and symptoms, you will find classic creamy white plaques. Okay, removable, but it will cause a burning sensation. So this one you can easily remove off. That's why it's called as, when you wipe it off, it will actually come off, but it will cause a classic burning sensation for the infant. Foul taste is seen, and you will find the lesion on the buccal mucosa, neck, and palate. Okay, so this is with regard to oral thrush. Now coming to erythematous or atrophic candidiasis, characterized by reddish appearance or erythematous appearance, as the name suggests. Okay, it is seen again on the palate and the dorsum of the tongue, and it appears as spotty areas on the buccal mucosa. Only the most important points has been put in the PPT. Okay, when you refer the PDF, there is more points available. Hyperplastic, you can see white plaques that cannot be removed. Okay, so when you compare hyperplastic candidiasis with oral thrush, the difference is that in oral thrush you find creamy white plaques which can be removed, whereas in your hyperplastic you will find white plaques that cannot be removed. So that is the difference. Angular cheilitis or perlish or angular chelosis, you can see it in both children and adults. You will find basically on the borders of the lips, okay, or around the corners of the mouth. You will find red fissured lesions, irritated raw feeling on the angles of the mouth is where you see angular cheilitis. Okay, so this is the classical feature of what oral thrush. So there is basically no teeth, only gum pads are seen, and the child is actually consuming only what breast milk and bottled milk. Usually, this all is because of lack of hygiene. Okay, what happens is because there is no teeth, they will not clean the area of the mouth. Because of ml applied on the. If ineffective, you can give instead of fluconazole, what do you say, drops, you can give fluconazole tablet 100 milligram. Okay, children who cannot swallow clotrimazole trosh is given. Can anybody tell me what is a trosh? Anybody? No, 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 no. Lozenge. You can say it's a lozenge. Okay. Just type it in the chat box. Okay. So that is called a strosh. Okay. So clotrimazole, children who cannot swallow, you will give clotrimazole trosh instead of tablets. Okay. Excuse me. Yeah. Now coming to angular cheilitis, you will apply what? Fusidic ointment or cream for 4 times a day. Okay. You will not give any kind of systemic medicine like what is a systemic fluconazole or clotrimazole suspension. You will apply fusidic ointment to heal the lesion in case of angular cheilitis, which is seen around the corners of the mouth. Now coming to the next condition, which is scorbutic gingivitis, or you can say scurvy. Okay, scurvy, you will be knowing the terminology much better. Vitamin C deficiency, severe vitamin deficiency in children is called as scurvy. Oral manifestation, bright red swollen gingiva. You will find ulcerative gingiva is seen, and there is profuse bleeding. Okay, just with mild irritation. Marginal and papillary gingiva are affected here. Okay, and severe pain will be seen. What are the treatments? Vitamin C supplements, because as obvious it is due to the vitamin C deficiency. You will have to give vitamin C supplements. Even for fruits which are rich in vitamin C is also like your citrus fruits, like your lemon, orange, etc. is also recommended. Complete oral hygiene care, dental care. What you have to do, you have to just give the supplements, and as a professional, you will have to do oral prophylaxis and gum massaging. Now, yeah, very important. As I told you, gingival enlargement due to certain drugs. Okay, so drugs reported to cause gingival enlargement is the following drugs. Okay, please Mark this in red, very important. Usually we ask this question in your exam. So drugs with different drugs, phenytoin. Okay, again, it's also known by the name dilantin sodium. It is an anti-epileptic drug. It's given for treating what? Epilepsy. So see, epilepsy, if you don't treat it, it can lead to serious complications. It's a neurological condition with fits and seizures as seen in this condition. So certain conditions you will have to overlook the oral, what do you say, side effects. Okay, so you are forced to give phenytoin. Okay, so this will come as a collateral damage, this gingival enlargement. So you will have to treat accordingly. You cannot immediately tell the child to stop taking phenytoin, because epilepsy is a more serious condition. Okay, so phenytoin you will give in epileptic patient. Cyclosporin for anti-rejection. Usually you give cyclosporin after for a transplant patient. Okay, because the body, for example, if a patient has undergone a renal transplant or a cardiac transplant, anything foreign which has been put into the body has a tendency to reject. Okay, that is the basic mechanism of the body. It will reject a foreign body. Okay, our body has that inherent ability. So cyclosporin is a drug which is given to prevent this mechanism of the body. So it is an anti-rejection drug which is given. Okay, so that the body doesn't reject the foreign graft. So very important, no? For a renal transplant patient, the body should accept the transplanted kidney. So if you don't give cyclosporin, it will be life threatening, so we have to give the drug again. Okay, so collateral damage is what? The gingival enlargement. Hope you guys are understanding. Okay, so again, cyclosporin is given, usually given in transplant patient. That is another drug which is causing gingival enlargement. Nifedipine, okay, calcium channel blocker, again a drug which is given to what? For a hypertensive patient, to lower your blood pressure. It's usually taken. This drug is also said to cause what? Gingival enlargement. Valproic acid and phenobarbital, again given for anti-anxiety patients, to reduce anxiety, and for epileptic patients as well. Okay, especially phenobarbital is given for both, like anti-anxiety, and it is given for seizures also. So all these drugs are important, having important medical uses. Okay, so we cannot immediately stop this drug, has to be taken. And the side effect is what? Gingival enlargement. Okay, so just keep a note of the names of these drugs. Okay, so phenytoin, major drug to use to treat what? Epilepsy. It starts after 2 to 3 weeks of treatment. Highest incidence is after 1.5 to 2 years. Okay, so after prolonged use, like almost like 1.5 to 2 years, obviously there will be gingival enlargement. The interproximal gingival enlargement involving buccal and anterior segment is seen. Here the gingiva is firm, pink, and fibrous. It does not bleed. Okay, very important. Whereas in a scorbutic gingivitis and all, you will find a slight enlargement with profuse bleeding. Growth of gingival lobulation increases and coalesces the midline, leading to pseudo pockets. So basically, you will find what? Because of this hyperplastic growth, obviously there will be a pocket. When you put a probe inside, no, a perio probe inside, you will find it like a pocket. But the funny part is, in some gingival enlargement, no, like hyperplasia, the probe will not even reach the actual gingival sulcus, but still you will find what? A probing depth. Okay, PPD is seen. So what it can lead to? Pseudo pockets. Okay, aesthetic, and it can cause aesthetic problem, and it can even lead to delayed eruption of the tooth in very young children. Speech impairment is seen, and there is difficulty in mastication. There is obvious chance of what? Secondary infection to be formed. So treatment, again, you will do oral prophylaxis. Surgical excision. See, you will have to do gingivectomy. See, if you look at this picture, no, you will find all these are pseudo pockets, not true pockets. Okay, maintenance of oral hygiene has to be done after surgery to prevent the overgrowth of gingiva, or to prevent the gingival hyperplasia. So now coming to the next condition, which is acute pericoronitis. So before going, okay, to this slide, till now, any doubts, guys? Anything which you want to ask me, or everything is clear?
All clear, doctor. Thank you.
Okay, fine. So acute pericoronitis usually seen with the eruption of first permanent molar. Okay, pericoronitis means basically there is inflammation of the pericorneal flap. When tooth partially erupted, a portion of gingiva covering creates a retentive area between the gingiva and tooth. So if you look at the picture where the arrow mark is there, you can see the mesial aspect of the tooth, and then there's a pericorneal flap here. Okay, so in between this, this area will be infected. Okay, so if oral hygiene is poor, the debris will be accumulated, causing severe inflammation in this region, and this condition is called as pericoronitis. Usually it is like why we say first permanent molar is, in pedo clinic we usually see it in first permanent molar, but more common is with regard to your third permanent molars. Okay, at the age of 17 to 21, when your third molar, permanent third molar is about to erupt, that time you will find it more commonly in your clinical practice. Here, because in pedo we find only we don't deal with 17 to 21, that age group, right? So that's why it's mentioned first permanent molar. Okay, so treatment: chloroxine mouthwash twice daily after brushing, saline irrigation to remove the food debris. Okay, surgical excision of pericoronal flap in very severe cases. So that was with regard to the condition. Now coming to the gingival conditions. Now coming to the periodontal diseases. First one is the juvenile periodontitis. Okay, so bear is the guy who has defined this. Okay, it's not the animal bear. Okay, so Baer defined it as the disease of periodontium occurring in an otherwise normal healthy individual, which is characterized by a rapid loss of alveolar bone, and the amount of bone loss does not commensurate with the amount of local irritant. Okay, so when I read like this, you will not understand what it is. Basically, what he's trying to say that the individual is healthy. Okay, but he is having a rapid loss of bone. Okay, he does not have any systemic issues. The individual is a healthy individual, but it is characterized. Why? Because usually, as I told you, in debilitating conditions like diabetes mellitus or immunocompromised state, you will find what periodontal disease. But here the individual is healthy, he does not have any issues, but there is still a rapid loss of alveolar bone. Okay, and the amount of bone loss does not commensurate with the amount of local irritants. Basically means there is some kind of, say for example, there is limited amount of calculus. Okay, so for that limited amount of calculus, maximum the patient should be having what, a gingivitis. Okay, or a localized anterior marginal gingivitis. Only in that region he is having what, calculus, and only it should be restricted to gingivitis based on his what signs. But in an individual who very with very less calculus, you see what, a rapid periodontal or very big periodontal bone loss is seen. Okay, so that is what is called as juvenile periodontitis. So basically the amount of bone loss, it is not proportionate to the amount of local irritants which is mawjood. Did you understand, guys? Okay, so basically
Doctor,
the amount of, yeah, problematic things which is there in the mouth is not actually correlating with the amount of bone loss. Okay, so that's why this is called as what, juvenile periodontitis, and the individual is healthy also. Okay, so, what are the clinical features? You will find an arc-shaped bone loss. If you look at the what do you say, the picture, the IOP, you can see an arc-shaped bone loss is seen. There is distolabial migration of incisors. You can see the central incisors are migrating more distally, creating a midline space also, and it's a distolabial migration of the incisors. Basically, there will be a maxillary proclination also of the teeth. Okay, and as a result, what will happen? There will be a midline diastema formation, self-limiting, affecting mainly first permanent molars and incisors. Okay, so now this juvenile periodontitis can be localized and generalized. Okay, so usually in localized, it is usually seen in your central incisors and your first permanent molars only. Okay, so localized juvenile periodontitis onset is around the pubertal age of the individual. Affected teeth is, as I told you, permanent incisors and or molars is usually seen. Associated microorganism, very important, Actinobacillus actinomycetum combatans. Okay. AAC, very important. Just make a note of it. It is the cause of what? Localized, not generalized. Okay. It is the cause of localized juvenile periodontitis. Okay. LJP. And greater prevalence is seen in black people. Okay. This is the distribution. And the causes could be, you cannot commonly tell. Okay. There can be different causes. Most common is hereditary or familial distribution. It's due to an unknown cause. Why it is happening, nobody knows. But studies have shown that it can be due to neutrophil dysfunction and a higher IG2 or immunoglobulin response. Okay, so basically, can anybody tell me how periodontal diseases occur in simple words? It is basically our own body which is causing periodontal disease. Do you know that, or you don't know that? Yeah. So basically, it is our body's immune response to a local irritant. Okay. So how this body is actually tackling the calculus and the plaque and the biofilm which is there, which has all these problematic organisms like your acnobacillus, acnomycetum commitans, your what do you say? Porphyromonas gingivalis, pivotal intermediate. There are different complexes of bacteria which are actually leading to what these perio issues. Red complex bacteria is there, orange complex bacteria is there. All these bacteria like your what do you say, capno site nucleatum, then fusobacteria nucleatum, capnocytophaga. All these are actually what bacteria which will cause periodontal issues. Okay, so when this bacteria is actually causing issues, our body responds to this bacterial threat. Okay, how they will release mediators of inflammations. Okay, so neutrophil is very commonly released. You have other factors like interleukin 1, interleukin 6. All these things are what creating what is mediators of inflammation, which will actually destruct the what do you say, periodontium. And most commonly it will release as an enzyme called as collagenase or proteases enzyme, which will actually cause what periodontal breakdown. So basically it is the uh, body's response to actually what to this bacterial threat, and indirectly it is causing damage to what our oral cavity or our periodontium. So if you want to imagine in a more simpler way, no, I will tell you an example. If you look at I hope you guys have seen the Avengers movie, right? So basically there are villains coming to destroy the world, and Avengers is a group of fighters which is trying to save the world. So when there is a fight going on, you look at the fight, no, the surrounding buildings are being destroyed, the cars are being destroyed, the street is going for a chaos, people are being killed. So that is called as collateral damage. So basically this is what is happening in your oral cavity. So we have the invading microorganism which are the villains, and we have the avengers which are the defense mechanism or immune response of the body. Okay, so when these two are fighting, it is trying to curb the microorganism. So the microorganism is being defeated, but what happens is the collateral damage, which is the periodontal destruction. Okay, hope you guys understood. Okay, now coming to generalized juvenile periodontitis, as you know, it is seen in onset late teen years. Affected teeth, there is generalized involvement of the permanent teeth. In your localized, you will find only in what your central incisor as well as your molars. Okay, so associated microorganism, again here it is Porphyromonas gingivalis, whereas in your localized it is what Acnobacillus acnomycetum comitans. Please know the difference, it can be asked. Okay, heavy deposition of plaque and catalyst with periodontal inflammation is usually seen. So here there is a what do you say, a correlation between the irritant as well as the periodontal destruction. Again, it can be due to a familial distribution, just like your localized juvenile periodontitis. So treatment importance of always it is better to early diagnose and treat and prevent if possible. Antibiotic treatment, usually they say tetracycline 200 milligram, very good. It has a high ability to be retained in the GCF. Okay, that's why tetracycline is a drug of choice for periodontal conditions. Surgical excision of infected epithelium and root planing, all your perio procedures for flap surgery like your modified midline flap, placement of bone graft, etc., could be done to tackle this thing. And periodic recall, one visit every month for 6 months, and then once in every 3 months as the disease is getting better. Okay, so that was with regard to the gingival and periodontal conditions. Any doubts, guys? Anything which you want to ask me, you can ask. If you don't have any doubts, I'll go to the next lecture. Yeah, thank you.